at least for myself, and I hope for all of you as well. For all of you that are doing event medicine, I know some of the fourth years are doing event medicine, kind of going out in what we call the pre-hospital care. I'm going to be focusing on disaster MCI triage algorithms, and I'm going to focus on a particular case that is somewhat dear to my heart, and it recently happened, and I think all of you will sort of associate with it. And I'll be also focusing on hospital and out-of-hospital care. We'll start here with a case that is not necessarily high-volume casualty incident, but it does sort of get you in the mindset of what we actually experience out there and what you can expect when you're getting ready for your ED here for TTAs and traumas. Okay, let me see here. See if it plays. Okay, great.
USC base, this is Rescue 25. We're on scene of a multi-casualty incident. We only have 3 patients. I have 11-year-old pediatrics in full arrest. Rescue 2 is going to be bringing that patient. I have a 46-year-old female, and I have another 50-year-old female that's altered. I'll get you the RAs who's going to be transporting them as they get on scene. This is Rescue 25. We have an RA2 coming to you with a full arrest.
And that's for the 11-year-old, correct?
11-year-old female, full arrest.
Do we have any information on her, like Brockler or anything like that?
No. She's in full arrest. We don't have any information. Paramedics are loading her up right now. RA2 will be transporting her to you, and they will give you the sequence number.
Okay, copy that. And then you said you had a 46-year-old female and a 50-year-old female.
Yes, 46-year-old female. What's her problem?
Okay.
She's going to be a compound fracture of the system. Okay. 46-year-old female with a compound fracture of the tib. Don't know what side yet. RA2, UFC knew you're coming with the full arrest.
So there's a total of 3 patients, correct?
Right. I have a 50-year-old female that's altered. I'll get you the rescue that's bringing her. 46-year-old female with the tib, RA17 will be transporting her.
Okay, copy that. And who's bringing in the 50-year-old?
I'll get you that right now. Hold on. We're waiting on another rescue.
Yeah. And what was the mechanism, I'm sorry?
Who's bringing the 50-year-old female? Yeah, got that. We don't know yet. RA17 got no. The 209 is going to bring her. Okay. RA209 is going to be bringing the 50-year-old female. Okay, RA209 is going to be bringing you the 50-year-old altered female.
Okay, copy that. And I'm sorry, what was the mechanism?
Mechanism is auto versus pedestrian.
Okay, copy that.
Pressure the system. Okay. 46-year-old.
Okay, just for the interest of time, so we have someone who's calling in, usually a battalion chief calling in because of the resources, right? So if you read down here, the MCI is defined as when personnel or resources are exhausted out in the field, right? So although it's only a 3-person or a 3-casualty event, they have called it an MCI. Here in LA County, we tend to call MCIs for 5 and or greater, but usually it's very subjective to whatever the scene is like. So apparently, you know, he sounds very stressed. There's a lot of chaos on scene. And what did you think of the MICN? Was she being helpful and doing her due diligence, or did you feel maybe she was a little delayed in what her actual role should be? Would you have wanted more information, or would you just know, I'm getting 3 patients and I'm just going to get set up for the worst? Is that what sounds about? Yeah, exactly. So mechanism was important, and then also you, in your mind, you just want to know how many patients you're going to be receiving approximately. It's never correct. In the end, you end up only receiving maybe half of the patients that you think you're going to receive, but at most 3, and you know that you're going to get a pediatric full arrest. So you at the very least, you're going to get set up for that 1 patient, right? So she's 11 years old. We wanted to know Broslow color. Yeah. So again, you just kind of work with what you have, 11-year-old, whatever, scheme you have to estimate a weight. In this case, it's age times 2 plus 10. So about, 2 times 11 is 22 plus 10, 32. So you kind of just go based on that. You grab your crash cart and you pull out your meds, your intubation, and things like that. This patient, it actually goes a little against what we normally do in MCIs. And I'll go over as to why that is necessarily. But she's 11-year-old. She ended up being green on the Broslow. She was negative on her fast. She had no cardiac motion. So then, the TTA they were all ready to pretty much thoracotomize this patient. And so they did. They ended up clamping the aorta. They did the cardiac massage, the usual, and nothing was going on, right? So then they clamshelled, okay? So the right chest tube was full of blood when the ED resident did that, and so they clamshelled the child. And, as you can see here, the liver was herniated, diaphragm was shattered. It was pretty much a catastrophe, right? So they called the patient dead, at the time. So again, I ask you to at least kind of think about it through this lecture. Is this good resources? I mean, I think in this case, it was absolutely appropriate to transport this patient. But again, think high volume. If you have 300 patients, if you have 100 patients, and you're on scene and you're trying to kind of siphon through the patients that are more salvageable, would this be the child that you transport first, or would it be the child that you label black and deceased? Okay, so now more food for thought. So during the initial response to a train derailment with 100 casualties, which patient should be transported first? So is it A, the 50-year-old male who's screaming in pain with an open femur fracture, but you don't see any active bleeding? So the 80-year-old with a crush injury to chest and abdomen with agonal respirations, the 6-year-old with a pulse and apneic despite your rescue breaths, or the 29-year-old with decreased breath sounds on the right and thready pulses. So who votes for A? Okay, B, C, okay, and what about D? Yeah, it's D. Yeah, this patient has the highest, chance of survival. With 300 patients that you have to go through, this patient's going to be tagged red. Right, so what would you tag A? What color? Yellow, yeah. The 80-year-old is almost black, expectant, which is gray, and then the 6-year-old, black, yeah. Okay, so we have this journal EMS MCI board that is very nice to follow, and you all can just simply go on it, and it automatically updates with all, every disaster, MCI, anything that's pretty much pertinent to the US or worldwide. So I call this talk EMS Timely Topics because I think that we should all be aware of what EMS does and what police do, but then also what you can do as well. As an emergency medicine physician, you chose a specialty because you're a jack of all trades. You will take care of any patient in any circumstances. So I'm going to go over certain things that you can do to remind yourself, kind of stay in tune with what's out there, the literature, what is supported and what is not. Again, let's just go over, natural disasters, active shooters, bombings, you name it, it's been happening this whole year. What I'm going to do now is I'm going to focus on this one case or this one event, the shooting in Vegas, simply because I don't know if any of you know of anyone that was there, but there were a lot of firemen that were there that are part of my department, and a lot of friends as well. So they, it's been deemed one of the very large massacre in the United States. So we're going to focus on this one just to kind of, show examples of what can be done. So a lot of the patients that showed up to trauma centers just pretty much showed up in cars, and they weren't transported by ambulance. So this one level 2 trauma center immediately called more than 100 physicians in. Okay, so and then they also called nurses, clerks, techs, volunteers, janitors, everyone that they could. The pharmacist pretty much said, let's open everything and let's just stuff our pockets with, paralytics, sedatives, anything, blood. So everyone just pretty much, carried everything on their pockets that they could. And one physician in particular stood outside and was doing triage on all these patients, and he decided that, they were going to set up a shop outside, sort of like the tent that we have done drills for, and then the patients then were kind of tagged as they came in. Okay, so I know also the fourth years went over this disaster drill as well, so this is kind of a reminder of what can be done as well. They were showing up in pickup trucks, right? They were also showing up in ambulances. Some police cruisers were bringing a bunch of patients in as well. So what do we normally drill for? What do we normally prepare for, right? We normally see patients come in with tags already. Well, what if there's 10 people in a pickup truck and you have to kind of go through these as well? What would you necessarily focus on first?
People that can get up.
Yeah, the walking wounded, right? So all of you that can get up and walk and move over to the green area. Some patients did come in with red tags, so they focused on those as well. They also noted that there was no medical records or any type of PFS that would register these patients, right? So how would they then keep track of all the patients that were coming in? So they were writing on the bed sheets, right? And they were going like hurricane alphabetical names. And then they would just kind of simply write gunshot wound to here, gunshot wound to here, laceration to this, blunt injury to this. So kind of very rogue, but I think very creative as well. So immediate life-saving interventions that were done in the ED were the chest tubes, the intubations. The ED docs were walking around with IOs. So those were their IVs, right? And anyone who needed blood would get them in the ED. Question? Oh, sorry. Okay, so the trauma surgeon grouped the patients by gunshot wound location. All those that had abdominal gunshot wounds ended up going to the ORs immediately. So they would just do damage control. And in the end, they just left the wounds open. Okay, so just everyone just kind of like wound management stuff as much as you could for hemostasis and tamponade, and then they would be left out in the ICU for a little bit and then gone back to close. Okay. So if you think about triage and what it actually means in MCI versus what you do here, you do it every day, right? So the nurses, are in the ambulance triage. We do it in ARMID. There's a bunch of triage that goes on every day in the ED. You as residents also go through triage, right? When you're north, you get slammed with a bunch of patients, like 8 patients at once. And so you're triaging to see which ones you actually want to see first. And what are you focusing on first, right? You're focusing on the possible outcome for the individual patient, where you want to focus on the sickest. So like it just says here, if you're the worst, if you look deathly or deadly, you're going to focus on the patient first. Well, you have to kind of organize your thoughts a bit in the MCI triage algorithm. So you want to focus on what's the best possible outcome for the greater number of patients, right? And so it's a little hard to think about that, but it is the way to kind of approach when you are involved in these event medicine, mass casualty events, disasters. So just to remind you, a lot of the medicine that we focus on in pre-hospital care, it comes from the military. So I have a lot of respect for the military. There's a lot that goes on in battlefield that we then are able to translate over to the civilian aspect. So the MCI triage algorithms that we're going to focus on today is one of them. So there's immediate, there's delay, there's minimal, dead, and expectant, right? And usually we think about these tags as the ones that we primarily use, but then there's these tapes that we can use as well. So these are very quick. They normally go on the right wrist, and you just you go immediately. And this you can do within 10 seconds, right? So your initial triage should be done within 30 seconds when you're in a large MCI. This is very quick and very easy. Then when you go back and you reassess, you can focus on this. You can always use this as well, but these are very quick and dirty way of tagging patients. Again, important to re-triage patients as often as possible. And remember, your process is dynamic, right? So does your patient remain the same, or do they decompensate? What are your resources? Are you going to get ambulances soon? Are you in a remote place where it's very difficult to get access? Is the threat still, active, right? So like in the Vegas shooting, the shotter kept on shooting and the threat continued and continued. And so what are your resources and what is your scene safety, right? And most importantly, communication between police and fire. Are you safe to go back out in what we call the battlefield or care under fire? So different things to consider. Okay, so next question. So you're working as a physician for a first aid tent at a local fair, and there has been a bombing. You find a 5-year-old not breathing. After repositioning the airway, the child is still not breathing. And if you recall from the jumpstart algorithm, what is the next appropriate step? So A, do you check for a pulse? B, do you begin chest compressions? C, do you label as deceased? Or D, do you provide 5 rescue breaths? A, B, C, okay, and then D, okay. You actually check for a pulse, okay? So we'll just go over that a bit. For children that are not breathing, you position the airway, you check for pulse. Then if they have a pulse, then you provide rescue breaths. Okay? You don't start chest compressions in an MCI, especially if there's an active threat. And he wouldn't necessarily be deceased just yet. And your 5 rescue breaths come later after the pulse. Okay, so the STAR algorithms, right? So very simple triage and rapid treatment. You focus on RPM, right? So respirations first, then for a pulse, and then your mentation. So again, like Taku said, all those who can walk, get up, and please come this way, right? And away from the triage officer. After you assess respirations, then you can apply this mnemonic 32 can do. And then for Jumpstart, which is for kids, you focus on this parameter of respirations, less than 15 or greater than 45. So for your START triage, again, all these are they're gonna get up and walk away from you. Then you focus on respiration. So you're going to approach, bring your tags with you. And for those that are not breathing, you position the airway, right? So you provide some jaw thrust. If they breathe, then perfect, then they become red. If not, then you label them as deceased, and you don't check for a pulse in adults. Here, if it's over than 30 breaths per minute, then they're immediate. If they're under, then you move over to perfusion. Then you check for a radial pulse, not a carotid, it's a radial pulse. And then for capillary refill. So if you have good pulses and good refill, then it's immediate. You move over to mental status. And if they're following your commands, they're delayed. If they're not following, then they're immediate. Okay, so any questions? Yeah.
Is this algorithm on the START tag?
No. No, but there are kits that come with charts and folders and those nice little vests that everyone gets to wear. Those do come in, but the tags themselves don't have this. No. Okay, so Jumpstart, primarily used for 8-year-olds and younger, and it's what we primarily use in the U.S. So for this 11-year-old, she would have been considered a young adult, so the Jumpstart wouldn't apply to her. We would apply the START algorithm, and again, if your resources are tight and very large volume, then this patient would have been labeled deceased. Okay? Okay, so the Jumpstart Pediatric MCI. So again, if you're able to walk and get out of the scene, then you go on to secondary triage. Then you assess for breathing. If they're not breathing, you position the airway. If they start breathing, they're red, right? If they don't start breathing, then you check for a palpable pulse, which was our question. If they don't have a pulse, then they're black. They should have been black. They're deceased. And then if they have a palpable pulse, 5 rescue breaths, and then if they still don't breathe, then they're black. Okay, and if they do start breathing, they're immediate. The 15 or 45 respirations, so if you go over on scene and a child is breathing, right, so it's yes, respiratory rate. If they're breathing less than 15 or greater than 45, then they're in respiratory distress, so you label them as immediate. If they're breathing somewhere in between and they have a good radial pulse, right, then you check fermentation. If they don't have a good radial pulse, then you're going to label them as immediate. Okay? Okay, so then, again, we're kind of talking about a quasi-semi-controlled environment where you have an MCI and everyone arrives and everyone gets tags and everyone gets transported appropriately. And then you have our ReadyNet system here in LA County that I oftentimes go through this for our EMS rotators, but just to refresh your memory, this is where we focus on ED saturation, who's open as CT scans, acute stroke centers, STEMIs, and so this is how a large network of hospitals communicate with themselves, right? So this is very nice, and then we kind of keep tabs of what's going on in the community as well, and not necessarily focus on our hospital only. So this is for MCIs, right? So this is an example of an MCI that was posted on our ReadyNet. This was back in 2015. It was a police vehicle who was versus pole. So we ended up receiving 4 patients, and they all came to USC, right? And they tell you who brought them, how many delayed, and where they are. And then eventually here in location, they then will tell you if the patient was admitted or discharged. This is really nice, especially if family wants to be reunited with their loved ones and so on and so forth. You can actually locate where patients went. For us, LACUSC, we oftentimes on a normal day, if we're not on black or any type of particular internal disaster, we can accommodate for 10 immediates, 20 delayed, and 20 minor. Okay, so we're a pretty good kind of bed capacity hospital, if you will. And this is very nice if you ever decide, or if you ever need use of this, come talk to me or go to the base station. It's very helpful. So back to the Las Vegas shooting, right? So major problems that people talked about were that volunteers arrived and they just wanted to help and they were kind of getting in the way. They didn't know how to help. They were doing things incorrectly. And so that caused problems. Chest compressions were provided on scene as the shooter was actively shooting. So that's a big problem. They were a target. They then became casualties themselves. So the egress on this event was very horrendous. You can just imagine the stampede, everyone trying to get out through narrow spaces. So a lot of gunshot wounds then turned into blunt trauma and then lacerations from just people stepping on each other. Transportation, the streets were closed. Everyone was walking everywhere. Just imagine kind of, havoc and chaos. So a lot of the lots were closed. People then eventually got out of the scene and they were flagging down just, drivers and eventually made it to the hospital. So a lot of chaos out there. So again, MCI is never really controlled or it's never convenient, right? So if you have your readiness system in any county that you are, or if you have an MCI that's going semi-okay, then you're in a good spot. But at the same time, you have to consider, is your threat still present, right? So your MCI algorithms, you're going to help assist those who are breathing and have a pulse, right? Like those algorithms have taught us. You're going to provide life-saving interventions only. These mean, by definition, you're going to open the airway. If you have a needle T, you're going to do a needle decompression. So if you have your 16 gauge, if you happen to have it, you're going to control hemorrhage and with a tourniquet. And then also the antidote that we normally carry here at LA County is a duodote, which is pralidoxim and atropine, and that's for organic phosphate nerve agent stuff. So we do carry that in our EMS catchment, okay? So those are the only things that are considered life-saving for MCI drills and triage. So just a little bit about tactical combat casualty care, what we call TCCC. We're not tactical, we're not police, but you do have to remember that military provides us a lot of information, a lot of medical assessments, and a lot of protocols that we then are able to translate over to civilian. So I think we have to start applying TCCC to our daily lives and just kind of, mentally exercise it, because you never know when that active shooter is going to come in, right? You never know when that bomber or that bomb is just going to go off, and you're going to have to kind of go into that mode, and you can't be, the normal layperson. You have to have that extra training and that extra knowledge, right? So again, IEDs, improvised explosive devices from Iraq War, we all learned that, tourniquets are not saving lives. So we used to not use tourniquets because we thought they were bad and we were losing limbs to them, but that's oftentimes better than losing your life, right? So then we started kind of swinging the pendulum over, and we now think tourniquets are fantastic and we use them for everything. Finger laceration, tourniquet applied, right? So, maybe it swung a little too far, but either way, if you can carry something, you should carry a tourniquet. And remember, the Boston bombing, the Boston Marathon bombing, a lot of the first responders and just kind of off-duty everything applied tourniquets, and it really saved a lot of people. So this was life-saving. So just remember that this is very important. TCCC teaches us to fight, to run, and to hide. So again, if there's an active threat, you try to fight that person or your way out. You run and you hide. Well, a lot of people in Vegas decided to not run or hide. They decided to go back and help people. And I would bet that if you're a medical professional, you would probably feel inclined to do the same. So just remember a few very simple, basic things. So you want to extricate the patient first, right? You want to pull them out from care under fire. And your goal is to treat the casualty as best as you can, prevent more casualties, including yourself, and then complete your mission, whatever that mission may be. If you want to save all the children that you can, then that's your mission for that day. So you go back and you try to extricate as many kids as possible. So you set yourself for that mission. Again, this is very military tactical, but I think that this is going to be something that we learn secondhand, much like we learn CPR now 5 years from now, simply because of so many disasters and active shooters and crazy things going out there. So just to remind you, For TCCC, you want to focus on CAB first. So think preventable death. So hemorrhage, extremity hemorrhage is the top reason or the top way that you can intervene to help people from dying. 60% of the deaths that occur in combat are from hemorrhage, tension, pneumothorax, and then airway obstruction. So just keep those in mind when you're trying to, again, be prepared or at least know what you should do when you're doing event medicine or putting yourself out there, like in a concert or something like that. You never know. March acronym is what we teach police officers and fire departments, but I think it's very easy for us to also use in our medical field. So massive bleeding and hemorrhage, airway, respirations, again, going down the MCI algorithm. And then don't forget hypothermia, especially if you have a prolonged transport time, right? Just try to keep your patients warm and as best as possible. Remember, this is one of the lethal triad for trauma. So hypothermia is one of them. Do you guys remember the other two that will kill you? Acidosis, yeah. What's another one? Coagulopathy, that's right. Okay, so again, the trimodal pattern for mortality and trauma, right, immediately, this isn't really not the patient you want to focus on, right? This is likely the patient that's going to become apneic from high spinal cord injuries or aortic rupture. So those are the ones that we typically call dead on arrival or dead on scene. So you don't work those patients up. These are going to be labeled black. You really want to focus on those that are going to have minutes to hours of death, right? So again, your hemorrhage, your TBI, if you can possibly accommodate that. And again, remember our trauma systems that have come a long way from the 60s where we used to just take patients anywhere. Now we have a very intricate trauma system, especially here in LA County, that catches these patients and can actually save lives. So this is where you're trying to focus on. The late death and trauma is days to weeks, and then this is the typical DIC sepsis or multi-organ failure. And obviously that comes later, but you're going to focus on these patients here. Okay, so again, just to recap, the mass casualty incident triage, right? You focus on MCI when the threat is over. If the threat is not over, then try to remember TCCC and how you just need to extricate this patient. And if you do decide to help others, then you need to protect yourself as well, and then focus on life-saving interventions. Jump start and start. The walking wounded need to be labeled minor, and they need to get out of your way, essentially, to make your assessments. You focus on respirations, your pulse, and then your mentation, which is, again, kind of interesting way of thinking, which we normally don't think of in the ED. The children do get 5 rescue breaths, and this is 8-year-old or younger. And then remember to reassess multiple times because your patients do decompensate and your resources do change, and you're seeing safety changes as well. Okay? And I think that's it for me. Yeah, any questions? Yeah.
Just that last one right there, the reassessment multiple times.
Yeah.
Maybe somebody you can go over because that definitely is not something I hear talked about a lot in this. Is how frequently should you reassess these patients who come in a mass casualty incident? Does it need to be done immediately when they get the door to make sure that the assessment was correct? And then physically, how do you do it? Because those tags are very annoying, right? When they get tagged red, there's just no way to then move them to a yellow.
Yeah, so if you can, to answer your first question, I think was as they approach your hospital and how can you assess them immediately. So you either keep them as what the tag was or you rip off the tag. And those tags are annoying because, they can only get worse, and hopefully they're not getting worse. And if they're not, then you just keep the tag that it came in. And then you move the green into that particular, area that you've determined green. Or if you haven't even had a chance, like the Vegas shooting, the hospital didn't have a chance to set up their tent that we conveniently have here for our disaster drill, right? So then what they did was they just moved them over to what we call adult waiting, back to triage in the hospital. So the green would be there. And then I think your other question was how quickly do you reassess? Yeah, there's no defined answer, but you do it as quickly as your resources allow you. So if you have 10 triage officers and you get a chance to then go reassess because you're not getting the influx of patients that are coming in, then you reassess as much as possible. There's really no defined time. No. I know.
I guess it's sort of like in my reading of descriptions of mass casualty patient care appropriately, that the reassessment is rarely ever done. I was just wondering, in your opinion, if it's worth it sort of assigning someone that job.
Yes.
Okay, you got to run around this place and make sure the yellows are all still yellow.
Yes, it is important to assign one patient that, and if again it's chaotic, and if you can control the chaos as best as possible, you should assign someone for that. Assign someone that's going to be standing with you as a triage officer, who then you can assign different roles. Be the communicator with the ICU and the surgery, suite, the ORs, and then also communicating out in the field as possible. So they're sort of called incident commanders in the field, and you can call them the same way here, pretty much the person in charge of everything and kind of overseeing that. But yes, to assign someone to reassess is very important. And if you can have multiple, that would even be better. Yeah. Yes.
So you said they were able to get the greens kind of out of the way.
Mm-hmm.
And then they have the reds and the yellows sort of in the same area.
Yes.
And then the ED team was doing chest tubes and starting getting IV access and intubating.
That's right.
And then the surgeons moved everyone by where the gunshot wound was
Yes.
and took all of the abdominal muscles to know.
That's right.
The head and the chest to see what happens.
Yeah, they went to the ICU. So the heads went to the surgical ICU, and they had a CT surgery unit. And so what they did is the ones on the chest would then go to the CT surgery ICU. Yeah, and they would just be watched there. So then the neurosurgery attending then kind of drove in and dealt with those as well, did burr holes, and you name it. They kind of just did very rogue military type, just damage control, and then they went back and they kind of fixed things. Yeah. Yeah, Steve.
One of the things that the docs on for Pulse in Orlando brought up at conferences is that they got hospital leadership, and in particular nursing leadership, folks up in the intensive care units, informed immediately, even before patients arrived. They ended up getting 34 patients overstayed in the first 20 minutes. And one of the reasons they were able to deal with that is that they got people on the back end already moving early on. So they were able to move people up to the unit. Oftentimes you have, it may not seem like it, considering oftentimes we're on foot black or whatever it is, but you often have more space and more resources than you appreciate. But it's important, if you hear about this in the base station, that if you're the Recess 2 star, for example, you start to mobilize other resources that you have, so you can tell them, hey, we need to clear out space, they need to notify the ORs, they need to call from the clinic. So early notification played a big role in Pulse, and I think has in other facilities. The other thing is, so if you look next to the ReadyNet in our base station, it's got a list of how many we can take, and I think it's 10 immediates, 20 delays,
And 20.
20 something else. And all of the trauma centers have that in their base station. And the goal after the second Metrolink crash was to distribute patients as broadly as possible. For those of you who aren't aware, in particular maybe our applicants, we've had two major train crashes here in the LA area, and we've learned a lot from that. Part of it was that in the first train crash, we had people with vital signs on scene who ultimately died, and because we didn't use as many trauma centers as we had available to us. The second Metrolink crash, we distributed our patients much more broadly. Everybody with vital signs on scene survived, and that's the goal. So early notification, make sure we're spreading the wealth. And if you happen to be on scene triage is different from what you're going to be doing in the hospital. Because maybe answer your question, on scene at least, we have an EMS captain that is in charge of the triage area, and one person delegated to each of the different color areas to consistently re-triage.
I think on the similar in terms of hospital distribution, I'm not sure quite what like the policy is here. You guys might know more, but some of the places I've worked at when it's a disaster, if you have like a medically admitted patient, like a pancreatitis or something, they go up to a hall like that on the medical floor. You don't even
Yeah,
know if
that's
that
what happens.
person. So
Yeah.
the other thing is, if you're the two-star and get that call, who in your ED can if you have a chest pain that's a soft call admission, it's waiting for stress test, think about just immediately discharging that patient. If you have someone admitted who's stable,
Yeah, those get, to answer your question, those unadmitted patients get sent up. Yeah. And so we try to, yeah, again, pull out as many patients as we can. And that's the drill that the seniors go over with the disaster drill 2 weeks ago, I believe. Again, that's a controlled drill, right? So you have to be ready for that uncontrolled chaos that you then just have to take control. And just if you can remember anything, remember what I just go over, just kind of very basic things, RPM, threat. And remember, the other thing with Vegas is that they had a lot of security there in the hospital because they felt that the shooter had other friends that might come and then shoot other areas, and that happens a lot. So again, I don't want to belabor this whole well, I do want to belabor this whole safety issue because it's so important. I think we're just not privy to it. We don't get taught, we don't get told, right? And so it's so important. So immediately this physician who took control of this triage up in front, he then spoke to security and called police, and they said, we need to make sure that everyone is safe before they come in. So that's top priority too. I want you to be safe as well, and then help. Yeah.
So you said that they called in 100 physicians and 300 nurses. How does that communication network work in a natural disaster where communications are disrupted?
Well, in this case, it wasn't. Oh, you mean on a natural disaster? Yeah. Good luck. Yeah, no, you're right, and even even our ReadyNet is satellite, and so that even is vulnerable to that going down as well. So again, it's great if it all works, and it's great if everyone calls, and like Stu said, the patients are distributed nicely and evenly, and everything's fair, but it never is this way. So again, like in Vegas, people were being brought in by pickup trucks, right? So you got 10 patients. You have to make quick decisions. Again, your goal is within 30 seconds to assess what your color is, and you either go or you go in the waiting room, or you come into my ED and I'm going to do a chest tube, or I'm going to intubate you. So immediate life-saving interventions. So yeah, no, there's no answer to that.
They do have dedicated protection channels for 911 for other responders, but in terms of communication to the hospitals and between the hospitals,
Mm-hmm.
it's very much region.
Yeah. Mm-hmm.
I was the resuscitating up in Seattle when this duck boat crashed into this tour bus full of college students, and we're the only trauma center, so we get everybody. And from my experience, and I think it would happen here in Stevens, there's no shortage of doctors, right? If it happened right now, there are 60 ER docs who would just go over and help, right? So that isn't the problem. There's enough, generally, once we know about it, if there's recognition and there's a call, everyone's working in the office will come over and help out. Everyone who's upstairs who works in medicine or surgery, fellows, and everyone from the university hospital will come and help. So that's what we do. The hard parts are really following the rules and military style, doing what the captain says and reporting up the chain. So whoever's making decisions has information, and then just obeying those decisions and not trying to be a hero and go outside of the protocols, but doing your job with your 4 patients in your little corner and not kind of trying to go beyond that. The second thing is, it's not a doctor shortage generally. If it's in a place like our hospital, it'll be a CT shortage, a lab shortage, IV equipment, IOs, blood. Those are the kind of things. And that all needs to be coordinated through the boss so that people who need the stuff most can get triaged the most. When there's 10 reds and 20 yellows and 30 patients all at once, that kind of deferring to the boss, I would just encourage as much as possible. Having been in it, when that happens, it goes much more.
Right. Yes, Andy.
So when I was in East County, we called it the New Year's Eve Staff-a-thon. We got 30 or 40 stabbing patients charging all at once. And the thing that they talked about is actually very similar to what Jeff said. If you're the doc putting in chest tubes and you're the doc intubating, you're not keeping track of everything. It's almost like a sin where that leader is completely uninvolved, not following any individual patients, and the people following patients are reporting to her or him, and that person is making decisions on
Yeah, so your leader or your incident commander or whoever the triage officer has to focus on the overall picture, sort of like running a code, right? You're not going to go and do that central line or intubate. You're the one that's running the code, although sometimes you might. But you want to be the one that's overseeing everything and not necessarily, like you said, sort of blindsided by your chest tube right now, and you now have 10 extra patients that need interventions, or the active shooter has now arrived to your ED, and now you have your staff that's also injured. So yeah, you have to focus on the whole kind of picture and not necessarily get involved in one particular patient care. Yeah. Thanks for all the stories and the shared experiences. And any more questions before we wrap? Yes.
I just want to emphasize how, like, if we get notification, just to reemphasize how important it is to get everyone out here. On 9/11, we got everyone in. Unfortunately, we got no one in. But the rapidity with which we were able, when you're working in the areas and you do what you always would like to do, which is like, geez, I wish this person in front of me would disappear. And here, like 99 times out of 100, it's like, they can safely disappear. People are like, no matter how much you don't know about that patient, you know a hell of a lot more about them and their care than the one that's going to come in, right? And so it was remarkable how quickly we were able to get people out, and how, and this day and age, everyone's going to be totally with it. Like the nurses will put, oh yeah, okay, there's a mask, they'll take it. They know that they can do that. And then you've got a huge ER with, tons of providers and nurses, and we can handle lots. So that's probably the best thing we can do, is just get rid of anyone in front of us.
Okay, thank you.